Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome our speaker with great honor, none other than Dr. Abhyudayo Verma, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD in Medicine, DNB, FACE, Associate Professor at the Department of Endocrinology at Index Medical College, Indore. And today, sir is going to discuss on a topic prolactinomas, medical versus surgical management. So, by taking not much time, I would like to invite sir and hand over this session to sir. Sir, over to you, sir. Kindly proceed.
Thank you, Mr. Faraz, and thank you, Team IGCP, for giving me this opportunity to talk on prolactinomas, surgical versus medical management. And before that, discussion about surgical or medical management, I would like to talk briefly about the prolactinoma diagnosis, and then we'll come to management, whether surgical or medical is appropriate, and where we can talk about the management, whichever is suitable more for our patients. So you can see here the prolactinomas are most common type of pituitary adenomas. Almost 50% of all pituitary adenomas are prolactinomas. And females, they have more chances of getting a prolactinoma compared to males. And here you can see male to female ratio can range from up to 1 is to 5 to 1 is to 10. And when we talk about microadenomas, which are lesser than 10 mm, 1 is to 20 also. So females, they have lot many chances of getting prolactinomas compared to males, especially in the reproductive age group of 25 to 44 years. And as earlier also I have told, microadenomas, especially in females, are more commoner, 4 to 5 folds than the macroprolactinomas. So, and when we talk about the size, the microadenomas are more commoner in females, but macro can be more common in males. So this is just the latest incidence and prevalence of the prolactinomas, the micro and macroadenoma. What are the clinical consequences? Especially we can see here in females, the oligo or amenorrhea, which is the most commonest problem in female, galactorrhea, infertility, premature menopause, and decreased in the bone mineral density. Then we have larger tumor size and more aggressive features, where we have more of the mass effect. We have hypogonadism in males, loss of libido, erectile dysfunction, gynecomastia, infertility, osteopenia, oligospermia, azoospermia. So here females will have small or microadenomas with the features. Males may have macroadenoma with lot of mass symptoms. And mass effect can be seen more in postmenopausal female and males. They usually present with headache and visual field defect, hypopituitarism. If the mass effect is quite more, it can cause other hormone lineage damage also. Apoplexy can also be there, and there can be invasion of surrounding structures also. So this you can see, males and females we have problem. Then we may have metabolic syndrome also associated with the prolactinomas. Diagnosis, we all know, we'll just go through a single measurement of serum prolactin. We should avoid excessive venipuncture stress, which can again change the or cause sampling error. It can be drawn at any time of the day. Breast examination in patients should be done with galactoria, which should not be performed immediately before the prolactin assessment, because the breast tissue handling may impact the prolactin levels. Level above the upper limit normal confirms the diagnosis. And usually endocrine societies against dynamic measurement. We can do usual samplings. Dynamic sampling is not much required. We can do it by the thyrotropin stimulation test, L-DOPA, domperidone. They're not superior to measuring a single prolactin. So, a single prolactin any time of the day, especially when the patient is not in stress, we can take the sample. Then we have these units of conversion, not much. Differential diagnosis is also very important. Yes, whether labeling somebody as having a prolactinoma or hyperprolactinemia can be due to physiological drugs, very common, renal failure, hypothyroidism, and some paracellular tumors, which can indirectly affect the circulation of prolactin and cause hyperprolactinemia. And these are some of the physiological pathological causes. Physiological are coitus, exercise, lactation, pregnancy, sleep, stress. Pathological are hypothalamic pituitary stalk damage due to granulomas, infiltration, irradiation, trauma, tumors. Then we have pituitary problems like acromegaly, idiopathic, hypophysetis, macroadenoma, macroprolactinoma, surgery, trauma, etc. Then there are list of drugs you can see here. A lot of drugs, most commonest cause also. Anesthetics, anticonvulsants, antidepressants, then we have dopamine receptor blockers, estrogen, neuropeptide, neuroleptics, prokinetic drugs. Lot of drugs are involved in increase of prolactin levels. So usually this is important. Higher in women than males, the assay specific normal values. Normally it is less than 25 mcg per liter, but if it is more than 200, usually it is due to prolactinoma or maybe because of some drugs. And if it is more than 500, definitely it is a big macro prolactinoma. So, yes, more than 25 can be mostly due to drugs or some physiological cause, but more than 200 is definitely a prolactinoma, and more than 500 is almost definite of a macroprolactinoma. Here you can see studies have shown other way around also what I was talking about. Even minimal prolactin elevation can be consistent with prolactinoma. So, substantial elevation of prolactin can also occur with microprolactinoma. So, these are just findings, but definitely we should always do the full diagnosis. And there are some pitfalls in prolactin assays. I won't go in detail of those because we have different prolactin, monomeric, dimeric, and then the IgA, IgA, all those can cause the problem in prolactin assays. So then problem is some problem where we have asymptomatic patients with high prolactin level found out during a routine screening, but sometimes we have large tumor and the prolactin is not that high, which can be due to hook effect, where there is a required serial dilution to eliminate an artifact required. So this can be, so don't get totally biased with just the levels of prolactin. It can be very problematic. Macroprolactin, yes, there are macroprolactin which can again change the uh, assays and the results. Mostly they are due to oligomenorrhea, pituitary adenoma, and galacturia. Macroprolactinemia, the Endocrine Society suggests screening for macroprolactin in asymptomatic hyperprolactinemia subjects. And current recommendation is the use of polyethylene glycol. And based on these observations, they say that this procedure removes the higher molecular weight forms of prolactin through precipitation, and only the monomeric forms remain in the supernatant. And this residual prolactin level is measured after precipitation with this polyethylene glycol, which corresponds closely to the monomeric prolactin obtained after the gel filtration. So, here the recoveries are less than 40%, which are indicative of predominance of macroprolactin, whereas more than 60% points to the diagnosis of monomeric prolactinemia. So, again, macroprolactinemia should also be ruled out, and this is hook effect I was talking about. I won't go in detail. We have these problems. So to overcome the hook effect, we can go for 1 is to 100 dilutions. And here you can see the imaging of prolactinomas. Here, this is the prolactinoma. You can see here, it is almost taking a lot of space of the pituitary. And we have giant prolactinomas. You can see here, this is the pituitary gland, above is the optic chiasma, and then we have all these ventricles and all, and can cause mass effect also. So according to the Endocrine Society, when we have a patient with male or female with the symptoms which we have discussed earlier, we go for prolactin levels. If there is a hyperprolactinoma, we have to exclude first pregnancy, systemic disease, hypothalamic or pituitary injuries, and obviously drugs. Then we go for the assessment of clinical syndrome and prolactin levels. If the prolactin levels are between 25 to 250, we screen for macroprolactinoma, and if the levels are less than 250, we go for sample dilution, and if it is more than 250, we can go for pituitary MRI, and here we can see whether there is a drug induced hyperprolactinemia, or it is due to microprolactinoma or a macroprolactinoma. Now coming to the management, this is important. We'll be discussing this, the medical and the surgical management. So our management goals are basically to lower the prolactin level, decrease the tumor size, and restore the gonadal functions in both males and females. We have medical management through dopamine agonists, and here we use bromocriptine, cabergoline, and pergolide. And they have this problem. So we have bromocriptine, cabergoline, and quinagolide. And here you can see cabergoline has got the maximum treatment efficacy. The half-life is also quite prolonged, so we may use it once a week or twice a week also, and the efficacy is also quite better than bromocriptine, and the symptoms resumption of volutely cycles are approximately same with both bromocriptine and cabergoline. Microprolactin Prolactinoma 85 to 80%, macro 70 to 80%. And tumor size reduction is seen in 77% with bromocriptine and 50 to 100% with the cabergoline. And here you can see the symptomatic restoration about the menses is about 82%, prolactin normalization 32%. So the amenorrhea, infertility, galactorrhea, sexual reported to improve to the tune of 50 to 80%. The sperm count, sperm volume improves by about 60 to 100% with the use of this dopamine agonist. Then coming to the tumor size, you can see here the tumor shrinkage is quite good, 70 to 80% with the use of the medical management. Yes, there are some metabolic effects with the use of bromocriptine and cabergoline. There are significant improvement in glucose metabolism and insulin resistance. So, this almost a decade back, bromocriptine and all were tried in type 2 diabetic patients because some insulin profile parameters were seen to getting better, but not very effective, so it did not work well in the market. Then there is a slight reduction in dyslipidemia also. And ultimately, studies show that if we use it for more than 6 months, we can get some benefit in insulin resistance, some benefit in dyslipidemia, and reduction of metabolic syndrome by approximately 20%. Then we have with medical management whether intensive is better or graded increase in the medical therapy is better. Studies have shown that intensive treatment with cabergoline was not superior to the conventional recommended dose schedule, and with respect to the time needed to normalize prolactin levels and to achieve 50% tumor shrinkage. So, nothing more aggressive treatment versus a slow gradual approach is equally efficacious. So we may not go for a very aggressive therapy from beginning. Then problem with the medical therapy is with chromocriptine side effects are quite common. Cardiac valvopathy is quite common with cabergoline, but only in higher doses. Impulse control disorders are also seen with this because they affect on the neuron cells. CSF rhinorrhea can be seen with these drugs, and tumor fibrosis can also be seen. So this can also create some problem if we have a big mass. So common side effects are GI, nausea, vomiting, vasodilation, postural hypotension, headache, nasal congestion, mood changes, sleep disturbances can be seen. Cardiac valvopathy, yes, we should get a 2D echo for our patients regularly, whoever is on cabergoline. So, baseline echocardiography and 5 years follow-up echocardiography if the cabergoline dose is less than 2 mg per week, or annual if we are giving more than 2 mg weekly of cabergoline. If we suspect cardiac valvopathy, switch to bromocriptine or refer to a pituitary surgeon so that patient can be stopped on medical management and referred for surgery. Some patients, susceptible patients, may have psychosis also. Some may have impulse control disorder also. CSF rhinorrhea can be there with medical management. Tumor fibrosis, constrictive pericarditis, pleuropulmonary fibrosis, retroperitoneal fibrosis can be there due to bromocriptine more compared to cabergoline. Cabergoline, yes, it is better in normalizing prolactin level compared to bromocriptine, and in reducing the pituitary tumor shrinkage. Follow up monthly to 3 monthly according to prolactin level. Every year we can get a MRI, visual field examination for macroadenomas, and associated other hormones should be checked, and bone loss or BMD should be checked as per the patient's status. Treatment response, we can see if the prolactin is getting normalized or not, or the tumor size reduction is there or not with medical therapy. And if this is not achieved, we can go for the treatment with surgery. So follow up after the prolactin levels are well controlled, we can go for stopping the therapy, and then every 3 months in the first year we can check prolactin levels and get a MRI if the prolactin level remains higher side after withdrawal of the therapy. Recurrence 26 to 69% usually in the first year after withdrawal. It is predicted by prolactin levels at the time of diagnosis and the tumor size from the beginning. Then we have some patients who have dopamine agonist resistance also. So there is failure to achieve a normal prolactin level on maximally tolerated dose of dopamine agonist, and failure to achieve 50% reduction of the tumor size. So these are some of the predictors of resistance of DA: male sex, greater tumor volume, presence of cystic, hemorrhagic or necrotic component, and longer time for prolactin normalization. Management, we can increase the dose, or again, if it is aggressive, then we may, or there is malignant tumor, we may go for surgery. So grade 2B are aggressive lectotroph tumors, have 20 times higher risk of progression compared to grade 1A tumor. These are the poor prognostic factors. Age less than 20 years, males genetic predisposition, densely granulated PIT1 positive acidophilic stem cells, mixed somatomammotroph tumor, and plurihormonal positive cells. We have malignant prolactinomas also, usually in fifth or sixth decade, and they are diagnosed many years before the metastasis and has been treated with high dose of dopamine agonist, or repeated surgery or radiotherapies can be required. So for treatment of malignant prolactinomas, yes, more than the medical therapies, palliative debulking surgery can be required, and they may require radiotherapy and the temozolomide therapy also. This I won't go in detail. Temozolomide is an oral alkylating chemotherapeutic agent with about 50% efficacy in tumor growth control along with surgery and radiotherapies. There are some alternative medical treatments also required. So, role of surgical management. See, you can see here, if the patients are not requiring responding to our medical therapy, role of surgical management can be there in patients who have resistance to cabergoline therapy, who have dopamine agonist intolerance, patients who have pituitary apoplexy, who have persistent optic chiasmal compression due to optimal despite optical medical therapy, they have CSF leak, psychiatric conditions in macroadenoma, they have symptomatic pregnancy related tumor expansion that is refractory to medical therapy, and women with worrisome macroadenoma who are planning for pregnancy. So these are some of the surgical indications where surgery is preferred more than the medical therapy in these patients. And obviously, with surgery, also there are problems like CSF leak, diabetes insipidus, meningitis, visual deterioration, and hypopituitarism. Neurosurgical outcomes you can see here with microadenoma are good, but with macroadenoma, the remission is just 34%. Role of radiotherapy can also be there if the prolactinomas are resistant to medical therapy or surgery, or there is a malignant prolactinoma. And this is the dopamine agonist therapy for the prolactinomas. And here we have to rethink the place of surgery in the prolactinoma management. So these are all you can see according to the size of the patient, the surgical fitness of the patient, and the reduction in the tumor size, we can go for the prolactinoma management. And this is another this thing, pregnancy and prolactinoma. This is another important topic, but we won't be discussing here. But yes, this needs to be mentioned here because we get patients in pregnancy with micro and macroadenoma, and we should consider medical therapy or surgery before pregnancy if there is macroadenoma. Breastfeeding also can trigger spontaneous remission also, and permanent discontinuation can be done in 66% of microprolactinoma and 70% of the patients macroprolactinoma also. Drug induced hyperprolactinoma, again, if we reduce the drug dose and treat them properly, the prolactinoma, the hyperprolactin levels can reduce. So my last slide, a single prolactin assessment with pituitary MRIs can be sufficient for a correct diagnosis. Males compared to females, they have a larger prolactinoma, which are more invasive, and they are less sensitive to dopamine agonist and may require surgeries. Biochemical pitfalls should be taken into account while measuring the prolactin levels, especially because of the hook effect and the macroprolactin levels. First line treatment should be tried with cabergoline, but for aggressive and malignant prolactinomas, temozolomide is a valuable treatment who do not respond to both medical and surgical management. And in pregnancy, serial prolactin levels are not helpful in monitoring. Monitoring can be done only by the clinical evaluation and if required by MRI. And bromocriptine can be used in pregnancy if we really require a dopamine agonist therapy. Thank you.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants who have joined this webinar. Sir, I can see, sir, we have received some questions. With all your permission, shall we take these questions?
Please, please, yes.
The first question is from Dr. Anevesha, and she is asking what are the underlying mechanism leading to the development of prolactin?
See, basically, there are a lot of genetic changes. There are, as I have shown you, some of the syndromes where prolactin can also be involved. We have like MEN syndromes and all, where we can have prolactinomas along with other pancreatic and other um, um, medullary thyroid carcinomas and all those things. So it can be a part of some syndrome or genetic component is there. And then we have most common with drugs. Usually, a lot of drugs, as I have shown, anticonvulsants, prokinetic drugs, which are used commonly. Some of the antihypertensives, they may cause increase in the prolactin levels. So first we should check for the drugs. We should check for even oral contraceptive pill use in the females, which can lead to increased prolactin levels. So I think if we go by the proper systematic approach, we can see most common causes which can be very easily make out, and if screened properly, we can get even the rarest of the syndrome also in prolactinoma diagnosis.
Thank you so much, sir, for answering this question, sir. Moving forward, I can see another question from Dr. Saurabh Jha, and like he is asking, what are the most recent guidelines for diagnosing prolactinomas, especially concerning imaging and lab test?
See, basically, lab test, as I mentioned, it's quite simple. It can be done any time of the day, but only thing we have to do it, especially uh, where we have a good laboratory, where the sampling errors, especially as I said, during excitation, after exercise, we should not, especially in anxious patient also, we should not do so. The patient should be calm. They should be off any drugs which are causing increase or the fluctuation levels of prolactin, and then we should test the prolactin levels, and obviously keep a account of the hook effect and the macroprolactin level also, which I showed, and we can discuss with the laboratory personnel. And MRI also, as I said, yes, MRI should be done in almost all patients where we have the cause which is unknown for prolactinoma. Like drugs, if we know that patient is on such drug, we may avoid if the levels are not high. According to my clinical experience, if the prolactin levels are less than 100, and if we have some cause like maybe drug or something, MRI can be postponed. But we have higher levels, in spite of knowing the cause, MRI should be done. And then repeated MRI, maybe after 3 months or 6 months when the patient is on therapy, we should do visual field charting should be done, so that there is no problem in the optic chiasma. So these are some of the guidelines which should be taken care while managing prolactinomas.
Thank you so much, sir, for explaining it. I hope that Dr. Saurabh has received his answer, sir. As I can see, sir, there is no more question. As I can see, Dr. Anvesha is writing, thanks for your response, sir.
Thank you everybody. Thank you all, and thank you team IJCP for giving me this opportunity, and happy festival time, happy Deepavali to everybody.
Yes, sir. And sir, like wish you the same, and we would like to see you in future also with different topics, sir. Till then, take care of yourself, sir. It was really
Thank you.
great to have you, sir.
Thank you.
Thank you.